Hi, everyone, and welcome to this talk by the Benzo Research Project. And I'm Sofia, the chair of Students for Sensible Drug Policy at Imperial, which is a student society. And we are really excited to welcome the Benzo Research Project here. And we are especially excited. I'm especially excited because in 2022, I was a volunteer for the Benzo Research Project once, helping them gather their freedom of information data. And also, AJ, who is the co-project lead, was once the chair and one of the founding members of our student society. Sadly, due to an unfortunate technical issue, we've lost the first 20 to 30 minutes of the live recording of the event, which is why we are re-recording them now. But around 20 to 30 minutes in, it should switch to the live recording from the event, where you will also be able to see the live Q&A that was going on. And now, without further ado, I would like to hand over to AJ.
Thanks, Sophia. Yeah, as I said on the day, this was quite a full circle moment for me, having chaired SSDP and studied at Imperial and now being brought back this time as a speaker. So thank you. But yeah, as Sophia said, my name is AJ Martin and I'm joined by Monica Richards, and we are the co-project leads of the Benzo Research Project. Today, we are discussing local and national approaches to young people's drug use.
We will be looking at a couple of different things today. So we've got, first of all, an introduction from us both, followed by looking at the policy report and seeing what the team has been doing, looking at national approaches to young people's non-medical benzo use. Then the research team will be feeding back on what they've found from the Freedom of Information campaign that we did on regional approaches to drug education and support, followed by a Q&A.
So a bit of housekeeping before we get started. So if you did attend this event, these slides will have been shared with you via email. Those joining us online could use closed captioning, and there should be closed captioning also on this video on YouTube. And we took questions and comments from online attendees through the chat function, as well as taking questions during the Q&A from both in-person and online attendees. And anyone who signed up to this event will be sent the 2 reports that our volunteers are discussing today when they launch this summer in 2024. Please do reach out via our email with any questions, feedback, and when these reports launch, please help us to spread the word.
Here is an overview of the wonderful volunteers that have been part of the project since, or many of them since September. It is very apt timing, given that just at the start of June, we had National Volunteer Week. So a massive shout out to the many volunteers that have built the project to where it is today, as well as those who have completed the work that you'll be seeing in this presentation. It takes us to a total of about 70 young people who have volunteered for us since July 2021 from around the world. And it is just, we wouldn't have been able to get to where we are without them. So thank you.
A little bit of background about the Benzo Research Project. We are a youth-led independent initiative seeking to understand and improve the lives of young people who use benzodiazepines such as Xanax and diazepam in the UK. Monica founded the Benzo Research Project in summer 2021 after seeing some of her peers experience harms relating to non-prescription benzo use. Over the next 18 months, we took on our magnum opus project, conducting multiple outreach campaigns, creating harm reduction content for our social media, and collecting testimonies from young people who use benzos to find out more about their lived experiences and how they can be best supported. In December 2022, we launched our research report based on these testimonies, and just 1 year later, Monica shared these findings at the United Nations Commission on Narcotic Drugs.
Our project aim is fourfold: to understand young people's motivations for non-medical benzo use, to collaborate with key stakeholders, including drug support services, NGOs, and people who use benzos, to increase media coverage of young people's recreational benzo use in a non-judgmental light, and to create and distribute harm reduction information to young people across the UK.
Some of you less familiar might be asking why the focus on benzos. Data from the Office for National Statistics show a steady rise in benzo-related deaths since the mid-2000s. It's worth noting that many of these drug-related deaths, and indeed many young people who use benzos, told us that these drugs are used alongside other drugs, including alcohol, stimulants, and opioids, which can increase the risks relating to their use. One thing that struck us particularly at the beginning of this project was that media attention given to any one drug is not proportional to their relative harms. For example, MDMA-related deaths are a cornerstone of media coverage on young people's drug use. But as you can see, benzo-related deaths are consistently higher over the last few decades. This is not to say that MDMA-related deaths do not deserve attention, but that benzo-related deaths don't seem to be afforded that same level of attention. In addition to this disparity in media coverage, we found that the same disparity could be seen in academia, where young people's voices were often not heard. So we took things into our own hands, collecting testimonies from young people who use benzos, finding out more about their lived experiences to hope to start changing the tide on this rising trend. And those 80 testimonies from young people who use benzos continue to be held at the center of everything we do. Impact has been a key focus for us from the beginning, turning these lived experience stories into actionable change, bettering the lives of our peers. We've been able to do some incredible things that I don't think any of us imagined when we first started this project. But some of these include having our research republished by various stakeholders, including the International Drug Policy Coalition and Youth Rise. Our team has been interviewed by ITV News, The News Movement, Sky News, and GQ Magazine, and we've presented our findings at various events such as the SSDP conference in Belgium and the most well-attended Drug Science Street Drugs webinar alongside experts in benzo use research. These findings were integrated into our partner Crew 2000's Drug Trends report in 2021 to 2022, which was taken to the Scottish Parliament. And last summer, our team attended the House of Commons, speaking to MPs about back-of-house drug testing at UK festivals. And this came following a concerning rise in synthetic opioids known as nitazines being found in illicit benzo supply. We're happy to see that back-of-house drug testing is continuing this festival season in the UK. And finally, as mentioned, last December, Monica attended the United Nations to platform youth voices on the global stage. Today represents our next step in making an impact for young people who use benzos, and we hope that you'll support us on this journey.
Thank you, AJ. So the first policy paper that we're going to show you is on preventing and reducing harms related to the non-medical use of benzodiazepines by UK young people. Here are the policy team members that are behind this project. And a massive thank you to, in particular, Arman, who has co-led this working group with me. Unfortunately, he's not able and wasn't able to be here in person because he is working in Laos for the UNDP. but he has been instrumental in getting this over the line, helping the team members to produce this. And so a massive well done to him and to everyone on the team for getting us to where we are today. So some key features of the problem. Benzodiazepines, or benzos, are prescription medications for anxiety, sleep disorders, and epilepsy. They have a high dependence and withdrawal potential. And there are concerns regarding prescriptions over the last few decades. Firstly, on overprescribing, this idea that GPs and practitioners may be providing or prescribing people, not just young people, but adults included, prescribing benzos at a rate that increase the chance of dependency. For example, with prescribing benzos for the medium to long term or more than the 15 or 2-week framework. There's also deprescribing, this idea of coming off the drug and doing it safely. So firstly, there's withdrawal management, meaning that we had, for example, some people reach out to us in testimony saying that their GP had recommended that if they wanted to come off the drug, that they would not prescribe it and that they would in fact have to take this via the illicit market. And as AJ has alluded to, there is an increasing rise in the concern of nitazines or nitazines, which we will also be discussing later. And that's why we've written there that it's linked to the illicit market. Also, there's, with young people, a higher likelihood of experimenting and taking risk, perceiving illicit benzos as being pharmaceutically made, and also being safe due to them being prescription medications. So some key features of the problem. Rise of nitazines in illicit benzo supply. This is a synthetic opioid that has been linked to 54 reported deaths between June and December of 2023, presenting an immense risk and public policy challenge at the moment. It was also mentioned at the UN ODC when we went in December as a concern raised by several countries across the world. There was a severe lack of awareness about benzos and harm reduction, with benzos often not being mentioned in PSHE curriculums, which is where drug information at school is provided. Lack of drug safety testing availability. Benzo withdrawals can be fatal. They are one of 3 main classes of drugs where withdrawals can be fatal, which leads back to the point about overprescription and deprescribing and shows how much of a difficult and sensitive issue this can be. And also the steady increase of benzo-related mortalities in the UK between 2005 and 2021. So this list is by no means exhaustive, and we discussed a couple of extra in the Q&A, but if anyone wants to reach out and ask a little bit more about where the connections lie, or if you feel like we've missed out a really big one, please do reach out because we'd love to hear from you. But in summarizing what increases benzo-related harms to young people, we collated these following answers. Long queues for accessing mental health support, local authority investment decline in adult drug support services, stigma, that's pervasive stigma within schools and universities, GPs, and even, sadly, some drug support services. Lack of research into this area, zero tolerance policies in schools, colleges, and universities, cost of living crisis, COVID-19, and Brexit and the current medicine supply shortages. From Harm to Hope is a 10-year drugs plan to cut crime and save lives that was outlined in 2021 by the Conservative government. The 3 main aims include breaking drug supply chains, delivering a world-class treatment and recovery system, and achieving a generational shift in the demand for drugs. So by 2024 and 5, it aimed to have prevented 1,000 drug-related deaths, expanded treatment capacity by 20%, and reduce the prevalence of county lines drug dealing. As you can see by the yellow arc, there is a huge number of organizations or departments that have been brought into this. And I think that shows and lends itself to the complexity of this issue, of this policy issue, about how it has multiple causes and multiple effects and therefore can potentially be described as a wicked policy problem. And it goes to show the amount of stakeholders that will be required to be able to tackle this issue effectively. It is not all bleak, though. We have seen some fantastic initiatives that have received strongly positive feedback rising up and developing over the last few years. And so one includes BOWS, the benzodiazepine and opiate withdrawal service that has been implemented by North Central London NHS. And this includes tailored advice, stabilising medication regimes, gradual reduction plans, psychosocial support. Similarly, on the right, you can see REST, which is done by our partners Change, Grow, Live. So the recovery experience, sleeping pills and tranquilizers. And this is in Camden and Islington, again with tailored advice and information provision. In the middle, you can see Changing Futures, a 3-year policy programme spanning 15 areas in England, which prioritises adults facing multiple disadvantages, who are often a group hardest to reach and also potentially hardest to measure the impact in terms of success or not. We've also seen the 1625 outreach service, which is a harm reduction service for young people. And in the bottom left, you can see a couple of the drug safety testing services that exist at the moment, such as Mandrake, The Loop, and Wedinos. Now, some of these will be referred to again later on by the policy team. And again, we'd love to hear from people about their experiences of these services so far. What suggestions have been made for change? Again, not an exhaustive list, but we thought that this was a good overview. So we have, for example, expanding harm reduction education, early interventions to manage anxiety and sleep, such as grounding techniques and meditation, regulatory measures to discourage routine prescription of benzos, research on the safer treatment alternatives or naloxone equivalents for benzos. So naloxone is often used to counter opioids, particularly if someone is experiencing an overdose. So we'd love to see research be conducted on finding an equivalent for benzos, enhancing healthcare support for dependency, improving access to mental health services, and increased access to drug safety testing facilities. The policies that we'll be going over today are 4. We have self-paced online GP training on young people and non-medical benzodiazepine use, whole system approach to ensure personalised and patient-centred care, increasing access to drug safety testing facilities, and reforming Key Stage 3 PSHE education.
Our first policy recommendation is to develop new online self-paced training for GPs specifically focused on addressing drug use among young people. General practices are essential in delivering primary care interventions and are especially effective in helping patients discontinue benzodiazepine use. Specialized training for GPs on managing non-medical drug use in young people equips them with the necessary tools to provide safe and modern care. Research shows that substance use disorders are most commonly diagnosed in young adulthood, but most treatment evidence comes from studies on older adults. The current From Harm to Hope strategy lacks adequate guidance on young people. Tailored training has consistently improved healthcare professionals' attitudes towards patients, which is crucial for effective treatment. Supportive and informed staff significantly impact the treatment journey, as discrimination in healthcare often deters patients from completing their treatment. The Royal College of General Practitioners currently provides e-learning courses for GPs, such as the Management of Drug Misuse course. This course covers diagnosing the severity of drug dependence, engaging substance users in the recovery, delivering safe and effective care, and awareness of the current drug policy regarding recovery. GPs who have completed these courses have reported increased confidence, better recognition of drug dependency, and improved patient services. However, these courses are optional and do not specifically cater to any particular demographic, including young people. While the Management of Drug Misuse course has been beneficial, there is a pressing need to expand this program. We propose developing additional, widely accessible, self-paced training modules specifically targeting young people's drug use. This training should address the unique characteristics and motivations of drug use among young people and be customized to meet the distinct needs of this demographic. By focusing on these aspects, we can better prepare GPs to support young individuals struggling with non-medical drug use and ensure their healthy development. If we do not expand the scope of GP training, we risk perpetuating barriers that prevent young people from receiving adequate support. Currently, young adults who do receive treatment commonly do so at a dedicated addiction treatment facility alongside older adults with little consideration of their unique developmental needs. Without enhanced training, these patients may continue to face significant challenges. We must also address the stigma surrounding non-medical drug use. Many patients have experienced negative and judgmental attitudes in healthcare settings, including hospitals and clinics. Such biases among GPs can undermine effective care and compliance with RCGP guidelines. Furthermore, the evidence for young people's drug use is not as easily available as it is for older adults. To counter this, we recommend offering mentorship to GPs during their training and securing additional government funding. These measures will encourage more GPs to enroll in courses that help them challenge and overcome these biases, leading to a more supportive and effective healthcare environment.
This policy aims to adopt a comprehensive approach to ensure personalized and patient-centered drug support in primary care. This involves prioritizing a whole system approach that incorporates multiple interventions to improve care for individuals using dependence-inducing medicines.
The next policy
By integrating
will
drug
address
support
the
staff
issue
into
of
multidisciplinary
drug
teams,
testing
this
facilities
policy
in the
ensures that
UK.
patients can receive holistic care from various healthcare professionals, including pain specialists, social prescribing link workers, GPs, mental health services, and peer support groups. This multidisciplinary approach is essential for implementing holistic, personalized tapering strategies and psychosocial interventions. But why is this important? Involving patients in decision-making regarding their treatment plans fosters a sense of control, enhancing treatment success. Healthcare providers can discuss the complication of long-term benzodiazepine or Z drug use, the benefits of discontinuation, and assess patient willingness to withdraw. This approach supports effective discontinuation through personalized gradual reduction. As such, the recommendation aligns with the NHS England 2023 strategic framework, which aim is to optimize personalized care, but also align with the NHS long-term plan, which seeks to outline commitment to multi-professional collaboration and the introduction of new roles in primary care. Another key focus is increasing the number of drug support staff. Research from Harm to Hope highlights the importance of drug support staff in providing comprehensive care. Also, social prescribing link workers connect people to community-based support addressing practical, social, and emotional needs that affect their health and well-being. Initiatives like the Benzodiazepine and Opioid Withdrawal Service, also known as BOWS, engage patients in shared decision-making and demonstrate the benefits of delivering services in primary care settings. Key services provided by BOWS include personal, regular support, and access to psychosocial resources. Run by medical and non-medical prescribers who are familiar with the specific needs of this patient cohort, BOWS exemplify effective patient-centered care in primary setting. This case study demonstrates the importance of personalized care and comprehensive support in managing medicine dependence and withdrawal symptoms. While it is recognized that existing healthcare structures may resist the implementation of new training programs and multidisciplinary approaches, overcoming this resistance is crucial for the success of this policy. Adequate resources, including funding and staffing, are also necessary for effective implementation. Tackling stigma within primary care delivery is also a core barrier which will need to be overcome. Collaboration with local authorities and third sector bodies ensures accessible and equitable services, prioritizing support for at-risk patients. However, primary care organizations may face challenges due to competing priorities, such as increasing the number of nurses working in the NHS or increasing flexible working options for NHS staff. As such, coordination and collaboration among various stakeholders, including healthcare professionals, policymakers, and community organizations, are vital to ensure services are accessible and equitable, especially for vulnerable groups. The longer-term goals of this policy align closely with the From Harm to Hope 10-year strategy. These include improving partnership between stakeholders, developing guidance for integrated care systems, and creating a commissioning quality standard to increase accountability among stakeholders and governmental organizations.
To expand drug testing facilities using mobile lab equipment and trusted community spaces to set up temporary labs where people can test their drugs. Based on the literature, we're advocating for anonymous deposit boxes, for individuals to be provided the choice of consultation type, and for services to be staffed by a mix of workers from outreach from drug and alcohol staff services, youth or harm reduction, and people with lived experience. So why are we doing this? As AJ and Monica alluded to, this is in response to the rise in benzo-related deaths, the increase in nitazines in the benzo supply, and the frequency with which much stronger benzos are being sold as less potent varieties. We're not the first drug policy organisation to advocate for testing, and there exists in different capacity testing facilities across the country. So we have Mandrake, which is the Manchester Drug Analysis and Knowledge Exchange, and was the first permanent city centre testing facility, and operates in a partnership between Manchester Metropolitan University and Greater Manchester Police to test found or seized substances and distribute harm reduction information. Then we have the Loop, which, as well as its back of house testing festivals, offers a monthly service in Bristol operating out the Bristol Drugs Project, and is the only regular in-person testing service in the UK. And then we have Wedenos, which is the Welsh Emerging Drugs and Identification of Novel Substances. Funded by Public Health Wales and the Welsh Government, it allows people to submit samples for testing through the mail. So what are the benefits of this approach? So the first is access. So the problem in the literature is that fixed sites at city centres often exclude people who live in rural areas or on the edges of cities due to transport or availability or cost of transport. And so using mobile labs that can be easily set up and transported to different places gives access to a greater number of people. Then we have trust, which is essential given the criminalized and stigmatized nature of drug use. It's often suggested that drug and alcohol services are the best location for drug testing. However, there's some disagreement in the literature about the suitability given their focus on abstinence-based recovery, which can be seen as in conflict with harm reduction, the stigma associated with such locations, and that they're often suggested as a way to appease police concerns. So this is why we're advocating for the use of trusted community spaces, which have been shown to facilitate trust with new user groups and attract a greater diversity of people who use drugs. And then we have a significant advantage of our approach is choice. So we're suggesting that People who use drugs should be given the choice of consultation following the submission of a drug sample. This could be either in-depth and face-to-face, a more scaled back consultation that focuses only on harm reduction, or through a text message providing basic information and the content of their result. In doing so, we hope to provide a greater degree of control over how the individual interacts with the service to give agency and autonomy back to people who use drugs. Similarly, the mix of staff from different backgrounds can give people a choice of who they interact with and make the service maybe feel more inclusive and facilitate trust. So what are the limitations with this approach? So first is the frequency with which it can operate. Moving around from location to location in this means that, moving around from location to location limits how often testing can run in one location. And our hope is that by being able to offer the service to more people, we can counter this. The next limitation is acceptability. I mentioned previously, drug and alcohol services are often used as a way to ease police concerns. And so the use of community challenge spaces may risk being challenged. And so it's our hope that the inclusion of drug and alcohol outreach workers is a way to offset these concerns. And then we have cost. Testing equipment is expensive, and the cost of traveling and hiring out spaces may provide a significant limitation if services are funded out of local council budgets, which are already stretched. So it's the hope that central government would fund either local or regional councils or charities who wish to set up their own services. And research highlights that centrally funded services are able to operate more securely. And then finally, we have sustainability, which the need to transport the equipment may raise concerns about CO2 emissions.
Lastly, we have policy 4, which is about reforming Key Stage 3 PSHE education to include benzos and harm reduction. So we noticed that from harm to hope, there was a reference to achieving a generational shift in the demand for drugs. And this also includes school-based prevention and early intervention. So our aim in this policy is to reform Key Stage 3, which is year 9 to 11 or ages 14 to 16, the personal, social, health and economic education curricula to include benzos, harm reduction information, and the risks associated with polydrug use. Why? Because the guidance recommends, and this is PSHE guidance, recommends teaching substance-specific information around the average age of first use. Benzo use generally begins at 16 to 18, but in some testimonies we saw initial use beginning at 14. And adolescents from troubled backgrounds may start experimenting by 14. Some benefits: informed decision-making for individuals. This can potentially help with the risk perception and reduction issue that we talked about at the start, enabling young people to support others if they take it and help them if ever they were in need or if they were overdosing, reducing preventable mortalities thereby. The EMCDDA, which is a European-based organization, noted that they saw a reduction of substance use and intention to use by giving young people this information, as well as a reduction in the transition from experimental use to addiction. Some limitations and risks. So the wider shift towards academies away from state schools as a policy initiative means less ability to change curricula, because with academies, they have the freedom to be able to choose whether they opt into the national curricula or not, making it difficult to distribute the information centrally. But we're seeing that 39% of secondary academies still plan to follow the national curriculum. Parental resistance, for example, with bias coming through and a lack of willingness to engage in such topics. Limited curriculum time, school financial constraints, and non-specialist teachers, for example, introducing bias in the same way that parents might. There, we see that external specialists could fill the gaps in teacher expertise, promote help-seeking behaviours, and increase pupil understanding. So that's it for the policy section. So we now welcome the research team to the stage, and thank you very much for listening.
Thank you, Monica. I'm really excited to be joined here now by two of our research assistant volunteers, May Allen and Rainer Geelmuyden, who I've been working with through a little window in my laptop for the last year. So it's great to see that they have legs. But today we're going to be sharing some of the emerging findings from our upcoming research report, using the Freedom of Information Act to investigate local drug education and support in England and Wales. This has been a huge collaborative effort with our 8 voluntary research assistants, some of whom couldn't be here today as they are spread across multiple countries. But a massive thank you for all the work that they and you guys have been putting in since September last year. And the team is led by myself and my colleague, Joanna Bright, who is jet lagged, so she's not here, but massive thank you, Joanna. Firstly, some background about drug education. Evidence shows that current school drug education is largely ineffective at promoting behavior change. That is, young people that experience secondary drug education don't tend to go on to using less drugs or experiencing less harms from them. Further, most schools don't evaluate the effectiveness of their drug education to begin with, nor involve pupils in the co-creation of its curriculum. This leads us to the question, is current drug education at secondary schools meeting the needs of young people? Unfortunately, many young people who use benzos told us that it doesn't. This man from Swansea suggested that, quote, drug harm reduction should be taught in schools, as the just say no tactic is an obvious failure. Several young people felt failed by their secondary drug education, leading some to experience preventable harms from benzo and other drug use. Some of these young people who experienced such harms reached out for support. The main place to go for support for drug use are drug support services. These are local, often council commissioned services providing advice, treatment, psychosocial interventions, and prescribing where needed. But services like these in the UK have seen major real-time funding cuts of 40% since the mid-2010s. This has decimated services and led some support workers to seeing over 120 people per week, naturally reducing the quality and effectiveness of this support. Several young people who use benzos told us that they experienced several barriers in accessing such support for their drug use, but also their underlying mental health conditions. These include long waiting times, stigma from both themselves and their peers, but also in some unfortunate cases from professionals. Young people feared consequences of reaching out for this necessary support, including worrying that they would have other necessary prescriptions revoked, including ADHD stimulant medication. Other young people were unsure where to go, and so turned to their first point of call for health issues, their GPs. But many GPs seem to lack knowledge on how to support people dependent on benzos, leading some people to being turned away. And a couple young people cited this underfunding as underpinning several of these barriers. A few young people that did manage to access support felt that the support did not meet their needs. such as this non-binary person from Sleaford, who said, quote, "The drug and mental health services in my area are awful. Absolutely zero support." Saddening sentiments like these prompted us to dig a bit deeper to find out what local authorities are actually doing to support young people who use drugs. And this brings me on to the Freedom of Information Act, or FOI Act. This is a law passed by UK Parliament in the year 2000, granting members of the public the right to access information held by public bodies, including NHS trusts and local councils, by submitting what is called an FOI request. Why use the FOI Act? Researchers have called this a powerful yet underutilized tool in social research, democratizing the research process, both by increasing transparency of the data collection, but also overcoming traditional institutional barriers to accessing such large-scale data, including negotiating access to this data with public bodies and going through lengthy bureaucratic ethical processes. And so our Freedom of Information team collected data from councils and NHS trusts in autumn 2022, led by Adele Preston. They requested data from 84 councils on the number of young people accessing and waiting for support for their benzo dependence, council commissioned drug education and support schemes, and evaluations on performance and staff training of local drug support services. They also requested data from 217 NHS trusts across England and Wales regarding benzo-related hospitalizations and associated mental health admissions, as well as GP and self-referrals for support regarding benzo dependence. We analyze this data using two methodologies in parallel. The quantitative or numerical data was analyzed using a descriptive statistical analysis, taking population data from the census 2021 to estimate the percentage of young people in any given area accessing treatment for benzo dependence. On the other hand, qualitative or textual data was analyzed using a content analysis based off Columbia Public Health methodology. And in short, this involves annotating text with key themes that arise from the data, in this case, relating to drug support or education, and quantifying and summarizing these themes. If you want to find out a bit more detail about this methodology, feel free to ask in the Q&A, and I'll answer the best I can off the top of my head, but we will have the methodology written in full in the report that comes out this summer. The key findings that May and Rainer are about to expand on include widespread issues in data collection and handling regarding drug use. Lived experience was largely absent from drug education resources that we received. And these resources in some cases focused on sanctions and repercussions to young people who use drugs, highlighting the risks from prohibition of drug use rather than from drug use itself. And finally, councils appeared largely unaware of how their commissioned drug support is performing.
So the overall response quality was generally poor. Of the 84 council and 217 NHS trusts in England and Wales that we sent our FOI requests to, 93% of the councils and 27% of the NHS trusts responded with either complete, partial, or no data. Despite a high response rate, more councils provided no data than complete data in response to each of our questions. Some of the reasons for not providing the requested data included key reasons such as the information not being held, which was the most common reason, the cost of collating the data, intellectual property, the data already being publicly accessible, personal information potentially being included, and commercial interests. Now, when it came to estimating the prevalence of benzodependence, we compared percentage rates of the number of people accessing localized benzo support to population data from the 2021 census. This gave us an idea of the number of young people that had become dependent on benzos in those areas. It also highlighted key issues with data transparency and the limits of using the FOI Act as a democratizing data collection tool. A significant limitation of our analysis was the poor data quality, where inconsistencies in reporting prevented us from drawing meaningful conclusions from the data analysis. Analyzing FOI data, even at a descriptive level, was hard for us researchers, which suggests that the FOI Act potentially needs to be reformed in order to make it easier for the general public to collect and understand FOI data independently. Young people have also highlighted significant barriers to accessing support in the UK for benzodependence, suggesting that our analysis underestimates the number of young people that are dependent on benzos. Many of these barriers are referred to in the testimonies that we collected from young people who have used benzos across the UK. You can find these in the 2022 report and on our website. Lastly, many assumptions were made regarding the FOI data from the councils specifically. For example, when given the data from councils that didn't explicitly say which age range their data fell under, we had to make the assumption that it fell under the 16 to 30 category, as this is what we were generally asking for. Now, in terms of the proportions of young people that have been accessing support for benzos, we asked councils how many people were accessing local drug education and support services. We found that Blaenau Gwent County Council in Wales had 7% of young people accessing these services, compared to just 0.01% of young people in Monmouthshire County Council, for example. This led us to question, why did certain counties have high proportions of young people accessing local services in these counties specifically? What are the higher performing councils doing that works so well? And how can we improve the worse performing councils in order to bring them up to the same kind of level? A handful of the councils also referred us to the National Statistics about Drug and Alcohol Misuse website, also known as NDTMS, because their data was already publicly accessible there. This was another barrier for the research team, as it required some navigation of the website in order to gain the appropriate information and data. In terms of the resources that were provided by the councils, the qualitative resources we received fell into two categories. These included drug education and drug support. We received a total of 33 education resources from 15 different councils and 11 drug support resources from 7 councils. These resources included things like leaflets, posters, lesson and workshop plans, and any direct responses from the councils detailing their local approaches.
So since August 2022 and the original collection of the data, it became clearly evident that much of the drug education and support was contracted out to third parties. 14 councils used charities and drug support services such as Change Go Live, and 4 councils mentioned using the police to deliver these. With the police, these could be split roughly into two camps. Police were firstly used as a method of providing the duty of care that schools provide to their students. This is seen in situations where a parent of a pupil was suspected or known to be using drugs, or if drugs were found on school property. And the other method was direct involvement in the curriculum. This could be through assemblies and workshops. One council did mention the use of people with lived experience. And there is currently a lack of evidence on the benefit of using people with lived experience leading, but in the What Works review from the Scottish Parliament, they have recommended that it is good. A paper by Stowe et al. Suggested that not engaging young people in the design and implementation of curriculum promotes alienation, specifically as adults are deeming what is appropriate to young people. So sanctions and repercussions also made up a large part of the responses that were given to us. And this was 9 resources across 4 councils. And as you can see, the most prevalent sanction or response was with criminality. And this echoes the fact that police have quite a large involvement in the previous slide. And it shows that schools and councils are taking an overwhelmingly punitive approach to drug education, mentioning specifically the restrictions on travel and the risk to future employment. And another thing that was mentioned, luckily, was harm reduction, and that was in 19 resources across 6 councils. And by harm reduction, we're meaning managing harms and acknowledging them, but whilst also acknowledging pleasure and empowering young people to make well-informed decisions about substances. The resources on harm reduction were roughly split into 2 camps as well. So these fell into harm reduction before taking drugs, and this was looking at safer routes of administration, location and setting before taking drugs, and also polydrug use. The second was how to minimize risks whilst taking drugs. This touched on safe sex and safe driving, what to do in the situation of an overdose or an emergency, and also the specific effects of drugs. So one council did provide a lot of information on methadone, which is a synthetic opioid used for heroin dependence. And this is a harm reduction measure as it is a legal and controlled alternative to opioids, and also minimizes the other risky behavior that may be associated with obtaining drugs. Within our support and outreach resource, there was one council that also mentioned naloxone, which I think we've touched on briefly before in the presentation. Again, this is another synthetic opioid, and it can be used by anybody to temporarily reverse the effects of a heroin overdose. This is free to obtain from different charities and support groups, and can be administered by everybody with a very short training session. And so, of course, this is a harm reduction measure because anybody can use it, and you could potentially save somebody's life by doing it. So there was no mention of drug checking in any of the resources that we were given. And as mentioned earlier by Chris in our policies, there is a lack of testing services available throughout the UK. So in terms of the current interventions that are offered by councils, advice and information is overwhelmingly the largest intervention that they put out. And this is a very broad category and a very broad range of resources. It included topics like how to stay safe on a night out. It was aimed at a range of people, going from the young people that are using drugs, their parents, and also professionals such as teachers. And it also looked at specific advice on specific substances. So as well, there were support groups that were available in quite a few areas. It was less frequent, but the benefit of this was that there was a community-based care and outreach method for young people. And less frequent measures that were mentioned were things like detox and psychosocial measures, and there was no mention of non-medical prescribing in the resources we obtained.
So in terms of evaluations of the drug support services, according to Section 8 of the Act of Parliament called the CARE Act in 2014, all adult services where service users are 18 years or older require evaluation by the Care Quality Commission, or the CQC. Now, we found that just 17% of services had been evaluated, whilst 19% had no evaluations. 18% of staff training had been evaluated, whilst 22% had no evaluations. This echoes issues in the public health sector, particularly with workforce development. It should also be noted that a significant proportion of councils' responses claimed that they had no information which was relevant to service or staff training evaluations. Many just didn't include or provide the data in their responses.
Oh, hello. I feel very official now. Moving on to the limitations that we had surrounding this work. The data, or lack thereof, from the councils echoes the United Nations Committee on Narcotic Drugs that the availability of reliable data on various aspects of drug use requires improvement. And without this data, we cannot formulate effective and evidence-based approaches and risk continuing the rise in drug-related deaths. The data not being held or refused on commercial interests relates directly to the procurement process and the competition between councils for funding. This stifles the best practice and resource sharing and creates a hostile environment. And it's also important to acknowledge that at the time of collection, Benzo Research Project was 1 year old, and with our layman's knowledge at the time, it may have been limited by our personal experiences with drug education and support. This means that in our original questions that we sent out to the trusts and the council, the phrasing may not have been specific enough, and this would open up to misinterpretation or loopholes to not respond. And underpinning all of this is a dire financial strain that is experienced by local government and the NHS.
So we are outlining, based on this work, 4 recommendations. Firstly, improving data collection regarding benzo and other related health issues to create a informative early warning system. This can allow services to be flexible and adapt to emerging trends. Second, we'd like to see more meaningful inclusion of young people in drug education curriculum development, tailoring it to their specific local and age-based needs. Further to this point, we'd like to see specific co-created young adults drug support. Largely, drug support is formed by children's and adult services, and young people around approximately age 18 to 25 or 30 have specific needs and specific drug use patterns, and so they're often shoehorned into one or the other. Creating specific services for this demographic can also facilitate co-creation with this age group. And finally, we'd like to see better investment into evaluations of services and programs. specifically regarding harm reduction approaches that are often left out. So that brings us to the end of our research presentation. And today you've heard from both our policy and research volunteers exclusive findings from their upcoming work. But when can you expect these reports? Well, our lovely policy team are anticipating the release of their report next month in July 2024. And the research team will be following them with our FOI research report in approximately late summer this year. If you signed up to the event today via Eventbrite, you will receive both of these reports in your inbox. You can also sign up to our mailing list to receive these and any future publications from the Benzo Research Project. And the QR code for that is on the next slide. So with that, I want to say a huge thank you to all of our volunteers and for everyone in person and online for attending. You can follow us on our Instagram, TikTok, and Twitter pages. Email us at the email here. And if you want to find out more, go to our website, brp.org.uk. Thank you.
We're now opening up to the Q&A, and that is both in person and online. We've got a microphone that I believe will be passed around.
Yeah, hello.
Yeah. So if anyone has any questions for us, I believe there might also be some in the chat.
Well, there's already a question from online, which has been there for quite a while, since the beginning of the talk. And they're asking, how can we get involved in this wonderful project?
Well, that's a great question. Yeah, so in terms of recruitment, we're formulating a process to try and streamline so that we can get more volunteers in. We're currently building working groups and trying to think about where the next direction is going to be. So then we'll make job descriptions or volunteer descriptions based on that. But feel free to reach out via email and we will be sure to talk.
Thank you.
Any other questions?
Yeah, I have a question for the FOI team. When you looked at the council differences, do you think that this kind of, do you think that this also, did you discover some kind of like regional difference in a sense that like it was a council, but was it also kind of like regional differences that could be due to socioeconomic differences in different councils or boroughs, or just is there anywhere to suggest that benzo use can be a bigger problem in some regions than in others, or was it just because the councils were like doing workshops that wasn't? Yeah, sorry.
Yeah, that's a good question. And I think as Rainer said, the data quality limits our ability to an extent to really kind of be firm on that, in terms of saying definitively that one council is better than another. It seems that more central areas see relatively higher rates. Also in the graph that Rainer showed, some of the top councils were ones that have recently gone into effective administration, submitting what is called a section 114 to the government, basically saying that they don't have enough money to operate services, which could lead to more people needing support because they're not being reached early on.
There were also papers to jump onto that, some talking about how higher prescription rates had been associated with coastal towns, which I thought was quite interesting, coastal towns and cities, as well as questions over the connecting the indice of multiple deprivation with benzo use and seeing a connection there. So there's definitely studies looking into it, and it's a big question, but there's definitely been experiences of people recounting to me having gone to elite private schools or public schools that cost a lot and seeing benzo use being used there too. So I think the class question is still one that is remains to be seen.
Hello, thank you so much for the talk. That was great. I had a quick question about like the methodology part, specifically about how you ensured that you're comparing kind of apples to apples when looking at different councils. Because obviously, if you're looking at a council in Wales versus Camden, I'm assuming there'll probably be a bit of a population difference there. So I was just kind of checking on that.
In terms of the like numerical data or the qualitative?
Numerical.
So the data was we used the quantitative, got these words. The quantitative analysis was led by my colleague Jana, and they turned the raw numbers essentially in treatment from councils into proportions using population data for the same region, essentially from the census, to try and make them comparable.
Right, that makes sense. Thank you.
We'll check some online questions.
Okay, good. Thank you.
Thank you. Thank you for this and congratulations on ongoing success. I was just wondering, aside from research and policy working groups, are you planning on expanding the organization into other working areas?
Just to clarify, is that whether we're going to be, would you mind repeating the question?
Aside from the policy and research space, are you planning on expanding your work into other areas?
Whether we can say that at this event is another matter.
We actually have a discussion planned for this next week. But there are a lot of ideas floating around about how we can more directly support young people who use benzos in the UK, as well as potential research more globally or across the pond.
We've recently made a partnership with a similar organisation in Canada. And they're quite interested in doing an international comparison. Very exciting. So shout out to them.
Thank you.
I'm also adding to that, that because we would like to support young people who use benzos more directly, we are currently in the early stages of planning a sort of peer advisory board, but advisory sounds a bit too distant. But trying to embed young people's lived experiences even more centrally, because our testimonies were a snapshot of 2022, and nitazines have since popped up that weren't around really in the benzo supply in 2022. So having people who have lived experience and living experience embedded in the project more directly is something that we're looking to pursue.
Hi, I was just wondering how you guys are planning to like spread the information in a wider scale, because obviously in order to achieve like the changes within the NHS in England, Wales, how are you planning to promote it?
So one of the key themes in the last event was this notion of passing on the baton, this understanding that because we're young people, because we're students or early career professionals, we do not have the manpower, the time, the funding, or even the expertise to necessarily take this on a national scale. So what we've done is, at least with the last report, and there's thoughts about doing it again in this report, is sending it out to as many stakeholders as we can to try and get them to have the data that they lacked, to be able to take it forward and and try and empower them to be able to use that data effectively within their organization, because it's such a big issue and because there's so many stakeholders that need to be involved. That's one of the key reasons why. Another way was we've engaged with the media, for example, Sky News, GQ, The Independent. We've been in discussions with lots of different journalists to try and help them frame their content in a way that's not stigmatizing and also correct in our understanding, as well as spreading it to student unions. So we've got quite an extensive lead spreadsheet that we've been developing for quite a while. So we're trying to send that out en masse, but also without getting blocked by MailChimp, but also try and get them to share it as well, because I think a massive part of our success has been through those people who have taken the baton and spread it. So we're very, very grateful to the community for that. We've got some excellent questions online coming through as well.
Thank you.
There was a quick note that naloxone is not an opioid, it's an opioid antagonist, so it blocks opioids.
So thanks
for the note. Savina said, what would better drug education in PSHE in school look like? So there is some emerging research on this, but as mentioned, current school drug education is pretty ineffective, and lots of schools don't evaluate their programs. But some of the features that both Scottish Parliament and the UNODC have outlined as being effective ways of providing drug education include the list has just absolutely gone out of my head. Yes, peer support and a multimedia approach. So not just lecturing young people about drugs and telling them don't do it, because that doesn't work, as we've seen for the last 50 years. But yeah, I definitely recommend having a look at it's called What Works in Drug Education. It's a really good, quite lengthy review. But yeah. Also, is there a way to get involved from Sheffield? Yes, we have volunteers from all over the UK and the world. Just get in touch.
I also wonder whether with drug education, going back to that question, whether removing the focus on sanctions would help, because we fear that when there's sanctions being advertised and shown, that it can reduce the feelings for young people of being able to approach others for support. If they're seeing it as stigmatized, they might be less likely to speak to friends, less likely to go to a teacher, especially in fear of a punitive response. So we feel like that might be a good way to go about it. Definitely better drug education. I mean, there's also a question of kind of like who the delivery is from. So this question of if it's from a teacher who you see every week, who you either have a good relationship with or not, potentially. We're wondering whether external providers would help to give more up-to-date information, because they've had to compete often for contracts to be able to do that. So the quality of information is probably better, more up-to-date, and potentially more regionalised. So we saw, for example, with the Welsh Council having a higher rate, wondering whether that can have an impact. Yeah, there's lots to consider. This idea about whether it's centralised and distributed, the same information, because at the moment, two young people in the same city might be receiving completely different forms of drug education. One which is much more biased or not necessarily as informed, and someone else who might have Change, Grow, Live come in as an organisation and deliver it, where they have a little bit more control over, well, they have more control over who can deliver that information. So yeah, it's a really good question.
I have a question on how the cost of living crisis is linked with the increase in benzo use in young people.
Patrycja is going to answer this one.
Where's the mic?
This one.
So cost of living crisis has been mentioned in the National Audit Office report from 2023. So this report was a review of the current From Harm to Hope strategy. So cost of living crisis has had quite impact on the ability to recruit new staff. So we mentioned before that the recruitment of staff increased. So the From Harm to Hope strategy increased the amount of staff, but that's when we talk about social workers, nurses, pharmacists, this kind of stuff. If we're talking about mental health specialists, like certified mental health specialists, like psychiatrists, psychologists, or junior doctors, for example, these targets weren't met. So yeah, I kind of went farther, but yeah, that's cost of living crisis caused like this insufficient amounts of staff.
And there's also the fact that with the cost of living crisis, so with COVID, for example, when there was an economic downturn, young people were often the first to be laid off on the grounds that they were often the first to be left off. It's kind of like last in, first out policy, seen as more dispensable or perhaps more, maybe in a transitionary period before they go to university or a different stage. So we just saw a large number of young people feeling really anxious and uncertain about the future. And I do feel like the cost of living crisis is also bringing similar feelings of uncertainty. And we know from our testimonies that people self-medicate using benzo. So that was our concern.
Thank you. So I just really wanted to applaud you for what you're doing, because as soon as I heard about it, I found it, I was so curious and interested. I'm like, I've got to get there, do you know what I mean? Because I just think it's so incredible that like you're working on behalf of, your youth. I'm a lot older than you guys, but I came here because I've got a massive interest. Personally, I was prescribed benzos for about 13 years, and I am still on a small dose. So I wanted to sort of find out from you what's the reception are you getting from the psychiatrists, psychologists, GPs? How are they responding to the work that you're doing? Because my experience, like they literally, they kept sort of diagnosing me with other things as I was in withdrawal. So they kept sort of trying to put me on other, and I was so weak and unwell. So I was like on a myriad of medication by the end of it, when actually it was just withdrawal symptoms. And another thing I just wanted to say is the drug and alcohol services. So I'm part of CGL in Camden, and I'm part of the REST project. And I think that there should be a project like this in every borough. And it's such a shame that it's only restricted to Camden and Islington. And there was one in Bristol as well that's recently closed. They lost their funding. And also Bowes has also lost their funding too. So yeah, I think it's amazing. And if like you want to sort of connect with CGL, like there's some people there that can come and do some talks and stuff. But yeah, I just wanted to know sort of how the GPs are sort of responding to what you're doing.
Firstly, I wanted to thank you so much for sharing that and for being here. I think as I mentioned before, I very much commend your strength in being able to paper. It's a really difficult journey, and we've spoken to so many young people who've been through so much as a result. And so it definitely takes an immense amount of strength to be. And so I'm really happy that you're here. You're like a large audience part for us. So it's a big reason as to why we're doing it. It's definitely echoes the motivations as to why we want to do this, because of we saw, we're hearing of other people having similar experiences and there not being any data on it. And that's why this was set up. As for GPs, often they're really hard to reach. And if I'm not mistaken, I have a feeling that they would not really want to hear from us as young people. We experienced a bit of that, definitely, kind of this idea of like, well, what would you know? You have never prescribed to anyone. And it's like, no, but we know people who have been on the other side. I think what's really difficult about prescription is there's no one guideline that should be given. Everyone's body's different, metabolism's different. The number of years or months that you've been on it and the strength of your dose can massively impact the time at which you need to take them. So calls to standardize this are perhaps misguided. I think that's what I was part of there was an expert workshop that we went to a few weeks ago at Bristol Uni, because they're doing a study looking at the co-use and patterns of use between benzos and opioids, and seeing if there's any patterns there to note. And that was definitely a disparity in people's beliefs. Some people calling for a standardized approach, others pushing back and saying, well, that's simply not possible, it's not viable, and it's not a good idea. If someone's been on benzos for 2 months, it's going to vary very much from their needs are going to vary so differently to those who've been on 15 years. And so that's why Sara's policy that she talked through today about the importance of it being patient-centered, personalised, and catered to their needs is really important.
And can I just quickly say one other thing? The thing that actually got me through, the thing that actually got me to where I am today is peer support. So it's, you talk about lived experience. When I was in withdrawal and I didn't know what was happening to me, I found the Rest Project, and I just went to my boss and I said, look, listen, every Thursday, I didn't even ask, I just said, every Thursday I'm going to be leaving at this time. I won't take a lunch break. And when I found this group, I hopped, skipped and jumped through the gate. And when I was surrounded by like people that were in similar situations to me, like I just burst into, I just could not believe that I didn't have to explain myself. And as I mentioned before, the drug and, sorry, I don't know why I'm doing that. The drug and alcohol services, they do really well for what they do, but they do not understand. I mean, what they suggested me do, like when I attended the drug and alcohol service, was ridiculous. Like if I went cold turkey on this medication, you know what can happen if you go cold turkey, and that's what they were saying. Because as you said earlier about it being an abstinent kind of centre, but person-centered all day long, and co-production. You know, the person that's involved needs to be part of their treatment plan. So yeah, again, well done. Hats off to you.
Yeah, the community aspect is really important. I think being surrounded by people where you are recognised and don't have to explain your experiences because you get it. That's so important.
Especially in an era where I feel like, I mean, pre-COVID, but definitely during COVID and post community and the sense of community, I feel like can be really difficult, especially with regards to problems and with stigma, people might be less likely to want to go and speak about it. It's terrifying and it shouldn't be happening.
So we have two more points, two more questions, I think, in the chat. I realise we're going very slightly over time, but hopefully you don't mind. Firstly, from Sara, hello from Crew in Edinburgh. Would there be more continued research in Scotland in the future? That is something that I think we would definitely be interested in. Obviously, a case of where we prioritise our time because there's a lot of avenues to take. But I think Scotland, particularly if people aren't aware, their benzo-related deaths, I believe, are the highest in Europe, and I think that extends to all drug-related deaths in Scotland. So benzos have been a particular issue there. However, when we collected testimonies in 2022, which we did through an online platform, the majority of them we received from England. We only received 2, I believe, from each of the other countries in the United Kingdom and Northern Ireland, which I think owes to where our team were based at the time. But I definitely think it's an area to explore.
Something to say also is that there is a lot, or there seems to be some fantastic initiatives coming out of Scotland that we think the rest of the UK could and should learn from, in terms of, for example, creating a benzo-specific task force and frontline staff being informed about or being trained in a trauma-informed response. So there's a lot that we can learn from. So thank you to Scotland and people working there.
Lydia asks, within your research, will you be looking at the differences in the use of benzos between different ethnic groups and the cultural implications in relation to uptake of services?
So something to say is so in our testimony collection, because we wanted to ensure that people remained anonymous, we weren't able to gather such identifying information. But we have an exciting project in the works where we were approached by people who have already collected the data, including with ethnic groups, if I'm not mistaken, and a lot more demographic information, and have asked us to help them analyse and synthesise it. And that's as much as I can say at the moment.
To be confirmed or continued. James responded to Savina's earlier question, asking non-stigmatizing and judgmental, non-judgmental, and acceptance that.
And this is about the PSHE education. What would be good?
Non-stigmatizing and non-judgmental, and acceptance that some, a minority people, will use drugs. Honest discussions referring good and bad effects and harm reduction. And a related point that Sara has brought up is that there are a number of evaluated, quote, evidence-based, quote, drug education programs that are available at the moment that are highlighting safer choices and prevention. But when asked about harm reduction, the providers are clear that drugs are very much connected to harm in young people. So please research and read all resources, being mindful of the language before making these programs. Harm reduction should mean harm reduction.
Okay.
Very much agree.
Are there any more from the audience?
Emma also brought up about drug education, that there's a cohort of young people who are educated at home where this could get missed. So this is where a multi-pronged approach needs to be taken. And I think drug education reform often gets kind of siloed into just secondary school education, and so then tertiary education, higher education, but also education outside of formal institutions gets missed out and doesn't take advantage of those avenues to increase awareness and help spread harm reduction.
Thank you guys so much for joining us today in person and online. It's been a fantastic discussion, especially in the Q&A. Some really good questions asked. Again, a massive well done to all the volunteers who have been working tirelessly week in, week out, with no pay incentive, other than a moral one. Since
Us included.
Since September. And so we'd very much love to hear from you guys about what you thought about the research and any ideas that you have. I mean, even in the chat, we've, come across some very good ideas about moving forward. So thank you guys so much for your support and being here. And hopefully it's not the last time we'll see you.